Thulium laser technology is emerging as a potential alternative energy source for endoscopic procedures and is already widely used in urology for endoscopic prostate enucleation and bladder tumor excision. The thulium laser allows for precise cutting, effective hemostasis, and limited thermal damage. Shallow penetration depth theoretically reduces the risk of deep tissue injury and perforation. Thulium laser-assisted ESD for gastric neoplasia was first described by Cho et al. Over 10 years ago. We present a case of a 68-year-old man with a 3.5 cm lesion in the proximal rectum identified during FIT-positive colonoscopy. The lesion was classified as Paris 1S JNET 2B, necessitating en-bloc resection. ESD was performed via thulium laser-assisted ESD. Here we can see a 3.5 cm lesion in the proximal rectum under white light. We then examine it using linked color imaging and blue light imaging, which reveals a central area demonstrating a JNET 2B pattern. Submucosal injection with hydroxypropylmethylcellulose was then performed. We proceeded with the mucosal incision using the 550 micrometer thulium laser. The laser cutting setting was 0.1 joules per pulse with a frequency of 80 Hz, delivering a total power output of 8 watts. To minimize carbonization, an underwater technique was employed, similar to approaches used in endoscopic urologic laser surgery. Continuous water irrigation was necessary to maintain a clear view during the incision due to vaporization of the epithelial tissue. One of the differences between thulium laser-assisted ESD and traditional ESD with standard knives is that the thulium fiber is much thinner, allowing for improved suction even through a 2.8 mm channel. Another difference is that with traditional knives, the tip can be anchored into the tissue, providing stabilization during the cutting movement. Since laser cutting is essentially non-contact, this stabilization is not possible with the current form factor. After completing the circumferential incision, trimming was performed around the incision using the cutting settings. Once this was completed, we applied clip and band traction to improve access to the submucosa. With traction applied and improved access to the submucosa, submucosal dissection proceeds more efficiently. Laser energy is applied in short bursts to the submucosa with constant water irrigation. Note the very shallow depth of laser penetration, making it a safe dissection tool. One drawback of this platform, compared to currently available needle knives, is a lack of ability to perform submucosal injection with the same tool. However, by performing the initial injection with a viscous agent and subsequently using the underwater ESD technique, the need for repeated submucosal injections is minimized. Here, we can see penetrating vessels, which traditionally would be precoagulated with coagulation forceps. However, with the excellent hemostatic capabilities of the thulium laser and using the settings of pulse energy 1.5, frequency 40 Hz with a total power of 60 watts, this area is easily dissected with excellent hemostasis. Here is the final cut of the remaining submucosa. Note the difference in carbonization between air dissection and underwater technique. The ESD was completed in 75 minutes without complication. The mucosal defect was closed with 13 clips. The patient was discharged home the same day. Final pathology revealed tubulovillous adenoma with high-grade dysplasia and clear margins. Compared to the conventional electrosurgical knives, the Thulium laser offers a shallow penetration depth, minimizing deep thermal injury while maintaining excellent coagulative properties. This case demonstrates the feasibility and potential advantages of Thulium laser-assisted ESD for colorectal lesions. Further large-scale studies are needed to validate its efficacy in broader patient populations and to define its potential role in gastrointestinal endoscopy.